Hi, my name is Ian Craven. I'm one of the neuroradiologists in Leeds, and this is module 1 of the BSNR Educational Programme on head trauma. These are the learning objectives which you can pause and read through, which will also be on your curriculum support tool. Essentially, when we're talking about traumatic head injury, we divide it into primary and secondary injury. Primary injury can be described as extracranial, when we talk about soft tissue swelling and fractures, or intracranial. And here we're talking about extraaxial or intraaxial pathology. The extraaxial is hemorrhage in the extradural, subdural, or subarachnoid space, and the intraaxial is direct brain injury, such as contusions or diffuse axonal injury. When we talk about secondary injury, this is the phenomenon we're trying to stop with our treatment, but essentially cerebral edema, which can lead to herniation syndromes and subsequently infarction and hemorrhage. So looking at primary injury first of all and soft tissue swelling, I suppose the most useful aspect of soft tissue swelling is to help you identify the underlying fracture. Almost every skull fracture has some form of soft tissue swelling overlying it. So here we've got some soft tissue swelling over the right parietal lobe, which when you scroll down, you find a linear parietal fracture crossing the squamosal suture and into the squamosal temporal bone. This is highly suggestive that there might be an underlying extradural hematoma. And there are also other surrogate markers of fracture on here, such as gas within the intraorbital space, and also some pneumocephalus just over the edge of the petrous apex in the middle cranial fossa. So soft tissue injury is useful to help us identify and work out the pattern of injury. It's also important in cases such as this, where here we've got a very large subgaleal hematoma, so all of this high attenuation blood overlying the skull is due to a traumatic birth, and you can see that the hypovolemic stress it's provided onto the baby has resulted in a very diffuse hypoxic ischemic event with some sparing of the basal ganglia, but loss of grey-white matter differentiation throughout the cerebral hemispheres. So this is sort of intravascular depletion from a subgaleal hemorrhage. Other hemorrhages related to birth or the birth trauma can lead to this pathology, which is a Kefala hematoma. You can see on the video here that we've got this sort of expansion of the skull vault with hemorrhage peeling off into the subperiosteal layer and stripping into the inner and outer table. This can be quite deforming over a period of time if it doesn't resolve. So that's the soft tissue swelling. Fractures. Fractures tend to be described in certain patterns. So here we've got a linear parietal bone fracture. You can again see the soft tissue swelling overlying it. It's often difficult in neonates and infants to differentiate between fractures and sutures. So having the soft tissue swelling is very useful, as are these 3D reformats. You can see here more of a widened fracture through the parietal bone. I would describe this as diastatic if it's greater than 5 millimeters. And here a 3D reconstruction showing a sort of stellate multifocal fracture in a child who had a non-accidental injury. But usually fracture patterns can give you a lot of forensic information. So here is a very common pattern of injury we see with a occipital linear fracture where somebody's hit the back of the head, commonly either falling downstairs or perhaps fight on a Saturday night and injuring the back of the head. Here we've got a depressed fracture. So this was from a direct attack from an axe, which is a depressed fracture. So it tells you a lot about the forensic nature of that head injury, and also tells you about the pattern of brain injury that you might see underlying it. There are some other types of fractures we see as well. So here, for instance, we've got a neonate with bilateral soft tissue swelling over the vertex, and we've got a linear fracture underneath there extending to both parietal bones. When you do the 3D reconstruction, I'm sorry about the colour tone on this, you can see that this fracture extends over the top of the vertex where the site of impact would have been. And this is called an Alice band fracture due to the sort of nature of it going across the vertex. It's an Alice band fracture. And here we've got indentation of the skull vault. You can see on the CT head that is actual sort of plasticity of the skull vault. The cortex itself isn't breached. And this is called a ping pong fracture because it's very similar to the indentation you get on a ping pong ball when you accidentally tread on it. It's the ping pong fracture. Fractures tend to heal very well, but here we've got a case of a fracture over 8 days, which hasn't healed, and it actually widened, and that is due to a sort of growing fracture. And here we've got a widening even further over 50 days. So we'll refer to this as a leptomeningeal cyst, or growing fracture. Then moving to the intracranial compartment, and here we've got a former head CT patient who was in a road traffic accident. And you can see he's got quite catastrophic facial bone fractures and skull-base fractures, but also a fracture going through the squamous temporal bone. The initial soft tissue windows wasn't that remarkable in terms of the brain injury. You can see a couple of contusions around the anterior skull base and some extra axial blood overlying that temporal lobe and the inferior frontal lobe. There's also a subdural on the left. What's quite remarkable is the sort of evolution of that change. So this is 3.5 hours later, and you can see the extent that extradural hemorrhage has increased. And this area of low density within it, when I sort of rock and roll through it, you can see the swirl sign suggesting ongoing bleeding. And an extradural hemorrhage is going to cause rapid expansion. You can already see significant mass effect. So blood, you tend to get a combination of these findings, particularly in high velocity trauma, extradural, subdural, and subarachnoid. We've seen that large extradural hemorrhage. When I report, I tend to move from the outside to in, and I report the soft tissue injury, followed by the skull fracture, followed by the extra-axial hemorrhage, followed by the brain injury. And I know some people will argue against that and just primarily focus on the brain, but this is a case in point where I think it's important to work your way from outside to in. If you're very experienced in trauma, then fair enough. You'll be able to sort of spot the different abnormalities anyway. But I think particularly when you're first starting off, having that sort of systematic approach to doing it will make sure you don't fall foul. So here we've got a case, as I've just scrolled through, where there's soft tissue injury over the right parietal lobe, right parietal bone lobe. And you can see this linear fracture going through the parietal bone, going down into the squamous temporal bone. Now, when you first look at the brain windows, the thing that you notice most is the mass effect. I think you see the left to right shift due to this large left-sided subdural collection of hematoma. And it would be very easy to focus on this and the degree of shift it's having, and relatively less attention on this smaller hemorrhage on the right. But actually, this lentiform hemorrhage is underlying the fracture, is likely to be extradural in nature. And if you decompress this side, this could rapidly increase, as we saw in the last case. So you have to sort of make sure that you put the emphasis on both for the neurosurgeons so they can manage the patient appropriately. Subdural hemorrhages can be very large at presentation. This patient's got ongoing hemorrhage within it. You can see fluid levels and low attenuation. And you can see that sort of marked right to left midline shift this time. This is the temporal horn of the right cerebral hemisphere pushed right away across the midline. So the midline shift is really quite marked in this case. Subdurals aren't usually difficult to spot. However, isodense subdurals can be, and here we've got subdurals that are pretty much the same density as the cortex. So this can occur in a couple of scenarios. One is if you're dealing with subacute or chronic subdural hemorrhages, so the blood products gradually lose density over several days, and become isodense to the brain. Alternatively, this could be a patient with a low hemoglobin. So patients with low hemoglobin can also present with isodense subdurals. So hemoglobin of 8 or 9 can give you this sort of pattern even in the acute phase. So if we look at different densities of subdural, then we can see that there's hyperacute areas. You've got low density within a hyperacute, then think of active bleeding. We've got acute subdural hemorrhage, that very high densities of 60, 70 grams per units. And then they begin to mature, and often you have tears in the subarachnoid, which can result in a mixing of CSF and blood products, and you can have some of this layering of acute blood more dependently within larger subdurals. So maturing mixed density, and then in the chronic phase, these are really chronic, but very heavily calcified subdurals, septations would lead you to think about chronicity. Traumatic subarachnoid hemorrhage you see in a lot of patients with head trauma, and on its own isn't going to cause a problem, but it can be a marker of more significant head trauma. So perhaps in a younger patient, you may be thinking about a diffuse axonal injury if you see subarachnoid in a closed head injury with no subdural or extradural hemorrhages. And I suppose the problem is the introduction of the brain injury that the patient often suffers from. And once you've built a pattern of how the head injuries have been sustained with the soft tissue injury, the fracture, you've looked at the sort of neurosurgical emergency that may be contributing to raised intracranial pressure in terms of the hemorrhage, then we can start looking at the brain injury that's occurred. And here we're talking about contusions. First of all, and this common pattern of contusions that we see would be this. The most common pattern we see is this sort of linear occipital fracture. So then you end up with hemorrhages, the contusions within the inferior frontal, anterior temporal lobes. And this is very much a sort of a contra-coup injury. So the impact and then the force of that injury results in a contra-coup contusion where the frontal lobes impact against the frontal bones, and you get this characteristic appearance. So when you look at the skull, the base of the skull, you can see that the sphenoid ridge, the petrous apices and the crista galli are all very fixed bony ridges which the brain can impact upon in an acceleration-deceleration injury. So you end up with these petechial hemorrhages around the lateral cortex, the inferior cortex, the frontal and temporal lobes, with some edema that develops afterwards, and this is the low attenuation that we're seeing. And we're used to seeing this maturation of contusions. So again, here's got a patient with sort of characteristic contusions. Again, a posterior impact. There was a fracture underlying that, and you can see this sort of similar pattern of contusions. And then when you see that maturation, this is just expected maturation. Contusions often increase in the first 24, 48 hours, and you get this blooming low density, and eventually you get quite marked volume loss in these areas. That's the sort of contra-coup and coup injury that you get. Here we've got the patient who had the axe injury, the depressed fracture that we saw earlier on. And obviously if you get a direct impact such as this, then you're likely to get a direct contusional injury, so not a contra-coup injury. This is the susceptibility weighted imaging. Not a contra-coup injury, but a direct coup injury. And you can see the sort of degree of cortical contusions there on the susceptibility weighted image, but nothing on the other side of the brain. So there's no contra-coup because they haven't had that same acceleration, deceleration injury. So contusions, we will also then see diffuse axonal injury. So diffuse axonal injury is often quite unremarkable on the CT. So here we've got a CT with a closed head injury. You can't see any significant soft tissue swelling or fracture. But what you have got is a convexity subdural hemorrhage that you can see overlying the right hemisphere. And just several other areas that catch your eye as you scroll through. So there's a parenchymal hemorrhage in the frontal lobe, just there, left frontal lobe. And then again, we've got hemorrhage within the ventricle at the back here, and sometimes you see hemorrhage within the fornices as you scroll through. So markers on CT suggest diffuse axonal injury, but certainly doesn't show you the extent of a diffuse axonal injury. So here we've got a flare sequence, and you can see that there's this flare signal change within the corona radiata, but also some sort of patchy signal change within the more peripheral white matter. And to see the full extent of diffuse axonal injury, you really need to be performing susceptibility-weighted sequences. And I think here, you get the full flavour of the injury. You get deep white matter injury of the anterior fornix white matter, fixed white matter structures. There's corona radiata and some corpus callosum injury. So anywhere where you have a fixed, tightly packed bundle of white matter, the axonal stress in the acceleration, deceleration, or rotational injuries, you get much likely to get diffuse axonal injury in these areas. Likewise, the corpus callosum, but the cortex is relatively spared. In severe injuries, that I'll move on to show you next, you have brainstem involvement. So here we've got the flare sequence and a susceptibility-weighted sequence of somebody with a grade 3 diffuse axonal injury. You can see the brainstem involvement. As you go back through the susceptibility-weighted imaging, you'll see the corpus callosum involvement, and then down the brainstem and cerebellar peduncles. So this is a really quite marked diffuse axonal injury. The next slide will show you grade 1, grade 2, grade 3 side by side. So this is the Adams grading system. So grade 1 is mild, grade 2 is called moderate, grade 3 is severe. And grade 1, really you only get to see some of the deep white matter. So here we've got sort of the anterior fornix, if you like, so of course the anterior fornix connecting through the anterior genea of the corpus callosum. And you can see that there's susceptibility here, but the rest of the brain is relatively well spared. So that would be an example of a grade 1 diffuse axonal injury. Here we've got a grade 2 that we've shown you. So additional to the deep white matter structures, we've also got some corpus callosum involvement. And then grade 3, in addition to corpus callosum involvement, you've got brainstem involvement as well. Secondary injuries are those that develop usually due to diffuse cerebral edema, and then once that leads to herniation syndromes, you can have infarction and hemorrhage. So here we've got an initial CT whereby you can see that there's quite marked diffuse brain swelling. You've got traumatic subarachnoid hemorrhage within that right sylvian fissure. You've got some inferior frontal contusions. But you've lost the basal cisterns, and it's crowding already at the foramen magnum. So there is diffuse cerebral swelling. Particularly around those basal cisterns, you'd be concerned that there's transtentorial herniation. And indeed, when you look sort of only 10 hours later, you can see that due to that transtentorial herniation, we've got posterior cerebral artery territory infarction. So the posterior cerebral arteries are being compressed against the tentorium from the descending temporal lobes. So they'll compress the posterior cerebral arteries, and you end up with this sort of pattern of ischemia. And then, as you go down the line, you'll see this sort of pattern where the volume losses sort of existed in those posterior cerebral artery territories, confirming infarction. And then the anterior frontal lobe changes are all about maturing of the contusions. If you have a large right to left shift, then you're likely to end up with something like this. So here's a large subdural hematoma, marked right-sided midline shift. And then the follow-up imaging 24 hours later shows ischemic change within the anterior cerebral artery on that side and the posterior cerebral artery on that side. So here we've got the anterior cerebral artery being compressed against the falx, so that's subfalcine herniation, and you've got the left posterior cerebral artery due to that transtentorial herniation. So ACA and PCA infarcts. So you can predict the pattern of secondary injury based on your primary scan. So is it transtentorial herniation and the PCA is being involved? Is it subfalcine herniation and the ACA is being involved? Or have they got coning and you're likely to end up with a diffuse hypoxic injury? Here's an example of a types of injury that you can get. So here we've got those multifocal cortical contusions. You can see 24 hours after the primary injury, they've made an attempt to decompress, so allow for decreasing the raised intracranial pressure. But they've still ended up with a posterior cerebral artery infarct. You can see that PCA is gone. But there's also this hemorrhage within the posterior pons, and this is a dura hemorrhage due to transtentorial herniation and compression of the brainstem. So diffuse axonal injury, slightly different pattern, but here we've got dura hemorrhage due to compression and transtentorial herniation. This study on the left just shows another example. It's a different patient. You can see that presentation, there's very marked cerebral edema and swelling. The convexity sulci have almost completely been effaced, and the basal cisterns have gone and they've started to cone. Okay, so this is really quite marked diffuse sort of cerebral edema. The follow-up imaging, you can see this is a catastrophic diffuse hypoxic injury, and this is just due to raised intracranial pressure and inability to perfuse the brain. So you end up with diffuse hypoxia, but also that raised pressure, this is Monroe-Kelly doctrine, results in parenchymal hemorrhage. So we've got some hemorrhage within the cerebral hemispheres there. We've also got a vitreous hemorrhage within the left orbit. That's just an example of sort of really quite gross raised intracranial pressure causing a secondary diffuse hypoxic insult. So hopefully that's a sort of overview of head trauma. The cases for this are all linked to your curriculum support tool, which is should be a companion to this, and you can access those through Paxman and scroll through them in your own time. Okay, so you'll have access to all those cases, and that's the sort of overview. Hopefully the learning objectives that will be in the curriculum support tool will be satisfied from this session. What we haven't done is deal with any of the NAI or sort of facial trauma, which hopefully will be dealt with in the sessions to come. So the next session you can hopefully view will be cervical spine trauma. This will be done live on the 26th of October by Dr. Stuart Curry and available shortly afterwards online. Okay. So thank you very much.